one, and go.
Good evening and welcome to PNP Live. I'm Brad Graham, co-owner of Politics and Prose, along with my wife, Lisa Muscatine. And thanks for joining us here online, where we've been able to move many of our events in response to the current pandemic and continued need for social distancing. In this virtual format, you can see us, but we can't see you. And you can still ask a question. To do so, just click on the Ask a Question icon at the bottom of your screens. And there you'll also see a green button to purchase this evening's featured book, Which Country Has the World's Best Healthcare by Ezekiel Emanuel. Zeke, of course, is a prominent authority on healthcare, and as such, often gets asked the question that became the title of his new book. It's a difficult question to answer, as you're about to hear, but Zeke is certainly the right person to ask because he's thought a lot about the topic, has a knack for articulating complex matters very well, and brings to the discussion of healthcare both medical and political experience. He's a trained oncologist with a medical degree from Harvard and a political scientist who served as a special advisor for health policy to the White House Office of Management and Budget during the first couple years of the Obama administration when he helped shape the Affordable Care Act. He's now at the University of Pennsylvania, where he chairs the Department of Medical Ethics and Health Policy and is vice provost for global initiatives, providing strategic direction for Penn's global endeavors. He's also senior fellow at the Center for American Progress. His new book is his fourth, and while the previous three focused on the U.S. healthcare system, this one has a chapter each on the systems in 10 other countries. Zeke then compares them based on various factors. His approach is systematic and thorough, but also very accessible and likely to be of great use to a wide variety of readers, from policymakers to patients looking for where to get treated. Zeke will be in conversation this evening with David Leonhardt, a Pulitzer Prize-winning journalist with the New York Times, who's held a number of positions in his 2 decades with the Times, including business columnist and Washington bureau chief. Currently, he writes the very popular The Morning newsletter every weekday. So Zeke and David, the screen is yours.
Thank you, Brad.
Thank you very much for that lovely introduction.
It's nice to see such a well-attended event. Zeke and I are excited to do this. We have known each other a long time. We're both, and we're also both frequent customers of the store. We're sad we cannot be there in person to do it tonight, but we're happy to do it here. So we're going to talk a little bit. We're going to talk about coronavirus. We're going to talk about the book. We're going to talk about the intersection between the themes that Zeke pursued in the book and the virus. We're also going to talk about some things not about the virus, which I'm sure everyone wouldn't mind a little bit of a break. And then we'll open it up to questions from all of you. So Zeke, this will be fun. We spend a lot of time talking about healthcare, and now we get to do it not just the two of us on the phone or in person, but with a few hundred friends here. So let's start actually with the virus, just because it really is on everyone's mind. And you, in the book, you mention a whole bunch of countries and what the U.S. maybe can learn from them. One that kind of stuck out to me was Taiwan, because it is right next to China, right? I think you say less than 100 miles. There are constant travel back and forth between those two countries. Of course, the coronavirus started in China. And yet Taiwan has been almost completely spared. You can cite the numbers, but I'd be interested in what you think Taiwan's sort of incredible performance on the virus says to us about what maybe we can learn from their healthcare system, both in fighting the virus now, but then longer term in terms of what kind of healthcare system we should want in this country.
Well, that's a great question. Taiwan was perfectly set up to be a disaster during COVID-19. As you say, it's less than 100 miles offshore. It actually has 1 million citizens working in China and therefore coming back and forth. It has scores, hundreds of flights to China. Perfect storm to actually have a terrible pandemic that was uncontrollable. But it didn't. And it wasn't just luck. So I think that there are at least three things, one of which goes to the heart of their healthcare system. First, the Taiwanese, because it was China, totally suspicious of the Chinese. And after SARS, they trusted them not at all. And they prepared and prepared and prepared to make sure that they were well prepared should some other virus arise. Second, they have a face mask culture. So people, like in many parts of the Far East, wear face masks if they're having a cold, if the air seems bad, for whatever. So moving to face masks to prevent infection was easy for them. But the real key that relates to their healthcare system is this health card. They started an electronic card that every person has. When they go to the doctor, they swipe the card. It's got connections to their medical record. It's got their basic demographic, their other info, and their personal information. And because they had that card, and that card is essential for the healthcare system, you give it to the doctor's office to check you in, and the doctor swipes it to bill, so that the Ministry of Health has a real-time perception of why people are going to the doctor and what the billings are of doctors. This information allowed them to that information in the health card was merged with the immigration and customs information. And so they could immediately see who'd been to Wuhan, who traveled to China. They could also see who had respiratory illness and was not positive for a influenza. And so they could suggest to the doctors, this person's at high risk, this person needs to be tested, and they could rapidly identify people. And so they never had a big outbreak. As a matter of fact, they have, last I looked, which was actually on the weekend, about less than 500 cases and 7 deaths in the whole country of nearly 24 million people. Yes, wow, no country has done as well as they have, given that population. And so I think we can learn a lot. That health card, we're very resistant in America to giving the information. We give everything to Facebook and Google, but Lord knows someone should have that information on a health card so that they could help us and prevent COVID from spreading. We're a little resistant. I do think that's something we can learn a lot from Taiwan. It also gives them some control, much better control over the utilization of services and how to pay doctors and hospitals.
And how do you think a health card system would work in the United States if you could imagine one? I mean, on the one hand, my instinct is a little bit, well, we're the United States, we're more individualistic, we would be suspicious of government running it. But on the other hand, I mean, you mentioned Facebook and Google. Based on what we've been seeing in recent years, I don't think I'd want to hand over my health data to a private company.
I totally agree with you. So my idea is that at least on the government side for Medicare and Medicaid, there's, create an independent third party on the premise that they won't commercialize that data. They won't merge it with other data unless it's for a health reason. It's not, to make sure that you're paying taxes or some other concern. And, to mine it for valuable health insights as to who's using the system, but also who's not using the system. Who's the system missing? We talk about these disparities in care and the disparities related to COVID. And a large part of that is there are people who aren't getting the kind of care they need or the follow-up they need. So I think that's possible. And, insurance companies could easily do that. But I can tell you that they have been, we work with a number of them, and they're incredibly frustrating. They can't tell you the real-time utilization. They have to wait for the doctor or the hospital to file a bill, and that can be literally weeks or even months later. So their data is not anywhere near the Taiwanese, which isn't exactly real time, but it's within a few days of real time, not weeks and months later. So I think we could get to a system like that without having to either trust big bad Uncle Sam or Facebook and Google. And I think our main suspicion of Facebook and Google is they're monetizing my data without my consent, and that really bothers people. I think people feel exploited by them and unable to control. I've got to be on Google. I've got to be on Facebook. I'm not on Facebook, but I got to be on Facebook, and yet I can't control what they're doing with it. And I think we could create a situation that's very different.
Yeah. And how would we give people incentives to get electronic medical records?
Well, I mean, actually, we've already done that. Doctors and hospitals have electronic medical records. The big challenge there is interoperability, sending the information back and forth. And the electronic health records, the big ones like Epic and Cerner, have made that extremely difficult because they want to keep market share and all sorts of other stuff that's about competition and money. We should have, when we passed the Recovery Act, which created the electronic healthcare system, we should have insisted on more sharing, that it had to be sharing. It had to be open APIs and open, allowing people to add on and reform things. That was probably an oversight of the rush to create the money. On the other hand, it is pretty clear that over the next decade, we'll not just have electronic health records, but we will be able to share the data and it will be liberated.
And yeah, I misspoke. I'm sorry. I meant the cards. Do you think we need the cards in the U.S.? Meaning, do you want to see a system where all Americans have a health card?
I don't know that it has to be a card, but we do need a system where there's near real-time flow of information about the utilization of services, why people are coming in, and who's not coming in, as I say, because I do think that's important. Also, doctors, sometimes patients go into the hospitals that their doctor doesn't even know, and then they're discharged and their doctor still doesn't know, so that they don't know, they have to follow up with them. That information has to flow much more freely and consistently. And again, I don't know whether it has to be a card or you could just have it on the phone or something like that. But I do think that kind of information flow is absolutely essential.
Okay, one more question about Taiwan, and then we're going to move to the big picture, leave the virus behind for a minute, the sort of big picture of the debates we have now in this country about Medicare for all. But you mentioned they have a mask culture. Can you just help us understand why masks ended up being such a disaster in this country? I mean, on a podcast that I used to do with my friend and colleague Ross Douthat, I gave him a hard time for wearing a mask. When my mom went out at the beginning and got some masks, I gave her a hard time for getting masks because I was listening to the expert advice. And I was just humiliatingly wrong about all that.
Right.
What happened, given that it now seems that masks are so important? How did we end up with this period of time where we were telling people not to wear masks?
So I think we were worried about PPE, about masks, not having enough masks for healthcare workers, because we didn't plan like the Taiwanese planned, and we didn't have enough, and we couldn't easily ramp up production. And more of our masks, we had lean supply chain, so they came from China, and that was screwed up by the virus. And so I think the initial is don't wear masks because we need to give it to healthcare workers. But then it morphed into, well, you might touch your face, you might do this. Instead of looking at, look, what's the key problem? The key problem is transmission. We need to reduce transmission, even a cloth mask. And by the way, well before 2020, there was data that the cloth mask did pretty good, not nearly as good as N95 mask, but actually a cloth mask with nylon stocking around is pretty darn good. And I think the rhetoric by the CDC, and including experts like me listening to the CDC, is shouldn't have done that. Then I did my own research on the history of this. And, when I had a show on MSNBC well before the CDC proclaimed it, I said, you got to stop this. You got to wear masks. And I think then, people really just began to look at the data, and the data are pretty clear. First of all, what's the downside? Well, the downside is, you can't see someone's face, but the upside is it probably reduces your transmission out and you're breathing something in. And therefore, it's on balance positive with very low risk and very low cost.
Okay. So obviously, we've been fighting about healthcare in this country for decades and decades and decades, right? And I think one of the things that a lot of progressives argue is it's not actually nearly as complicated as the kind of mainstream American political system makes it out to be. That every other rich country in the world spends substantially less than we do. Depending how you look at it, they have results that look roughly as good. We just need to move to single payer, and that will take care of this. And that would have seemed like a political pipe dream to many people 5 or 10 years ago. It seems sort of more within the ballpark of plausibility now. But setting aside or not the politics, I guess I'm interested in you seem to think it's more complicated than that, right? You've written this whole book about it, right? But so I guess I'd like you to take on the question. I'm sure we'll get it if I don't ask you. Why don't we just move to single payer and essentially solve this problem?
Hey, I'm so sorry to interrupt. Hey, David, could you scoot a little bit closer to the microphone?
Yeah.
Your voice is just a little bit faint.
Yeah.
Thank you so much. All right.
So I took the question to be, why don't we just jump to single payer? First
Yes.
of all, the world, their single payer may solve one problem, which is a financing problem, but it doesn't solve lots of other problems or other issues in the healthcare system that, you know, are included, like how do you deliver the care? What's the cost at the point of service? There are many other issues, you know, how good is your mental health care? How good is your long-term care? So there are many other issues than just how do you pay for it. Second of all, there are many countries in the world, including ones we identify, that don't do single payer in the way that most Americans think of single payer. You pay the government then pays hospitals and doctors, and you get the care. Germany, the Netherlands, Switzerland are cases where people actually buy private insurance. They choose from private insurance. In the case of Netherlands and Germany, they get a choice. In the Netherlands, it's like 22 companies. In Germany, it's around about 100. It's always dropping there. And then the government pays them a premium for you. You also have to pay a small premium. Lower income people are subsidized. Their premium is subsidized. And so you have a private system. The money does go to the government and then to the insurance company, but it's really the insurance companies which are paying the doctors and organizing the care. That's perfectly possible. Those countries have 99 to 100% coverage. You don't need to pay all the money to the government, have the government pay doctors and hospitals to get 100% coverage. So, you know, it's how you structure the system. And I do think we do have the most complicated system by far in the world. And I should add, that adds a lot of costs. A lot of the administrative costs we have, which are, again, by far the highest in the world, are because of the complexity of the system. Remember, we have Medicare. You got traditional Medicare, then you got these private plans on Medicare. You got Medicaid in each state. You got employer-sponsored insurance. You got the VA. You got TRICARE for the Defense Department. It is nutty. We could simplify it, and that would be a great thing to, you know, basically you got employer-sponsored coverage, you don't like that, or you don't have it, you get one of these programs where you can select a private insurance company and the government pays a premium. We could have that, and I think easily get to 100% coverage, and it would be administratively easier and cheaper for most people. So I do think moving in that direction is right. I wouldn't necessarily call that single payer. You know, we Americans have a very complicated relationship with insurance companies. We hate them. We love when politicians bash them, but then ask us to give them up. No way. You know, all those polls about Medicare for all, there are two things that dropped Medicare for all in popularity. One was give up your private insurance company, and the other was you're going to have to pay more taxes for it. So we're very complicated in you know, our feelings about insurance companies. I don't think we're getting rid of them. So let's work within that framework, and there are plenty of good models out there to work within the framework.
So among those models, one that Bernie Sanders talks often about is Canada, right? He represents a state that borders Canada. What do you think, given how many similarities Canada and the United States have, what do you think is the number one or one or two lessons we should take from Canada and really mimic?
What we should take from Canada and mimic? Well, they actually, first of all, there's not one system in Canada. So that's a hard question to ask. Each province really runs its own system. They have sort of minimum federal requirements, and then provinces craft its own. One of the things I do like about Canada is that they have a very robust primary care system, and their primary care doctors are actually paid a fair amount of money. And I think that's a very good thing. I would say that there's a lot of things I actually don't like about Canada. First of all, it might surprise a lot of our listeners. The Canadian Medicare system doesn't cover drugs. So it's the way America was before
Part D.
Part D, right, in 2005, 2006, and it's still that way. So second of all, they're not doing a great job of coordinating care for chronic illness. One of the big things we looked at was the coordination of care for people with chronic illness. The best thing for people with chronic illness is not to go into the hospital. That's acute care. You need constant daily attention to a chronic illness because you're going to have it now to the end of your life. And that requires a very different model of care, mainly outpatient, mainly house focused, where the hospital, the healthcare system, the doctors are proactive, reaching out to you to help you self-manage that illness. Canada actually hasn't pioneered that kind of care as much as we have in the United States. So I'm not sure that's the model I would personally emulate. I know that Bernie Sanders likes old traditional Medicare. That's Medicare that was sort of in vogue in the 50s and 60s, but I don't think that's what the people need today. We know that people on traditional Medicare often have, 9, 10, 15 doctors that aren't well coordinated, and that's not optimal for chronic illness.
What do you think? Which countries can we learn the most from? Which countries have aspects of their system that realistically we could relatively quickly move toward?
Well, I look at what do we want to improve, and then I look for the countries that have that and study it. I don't look for the countries and then, what can I learn from the countries? So I'll tell you one thing that it's a sort of big hobby horse of mine. If we're not going to improve the whole healthcare financing system, it's paying for children. Right now in the United States, if you're a family, the family bears the cost of their kids' healthcare. So if you look at individual health coverage, it's about an employer sponsored, about $7,000, of which the employee directly pays $1,000. I mean, they technically pay the whole thing, but directly pay $1,000. And then family coverage, of which it's $20,000 for a family, and the family pays about $6,000. It's an enormous amount to pay for kids. Every other country, the Netherlands, Germany, Norway, it's the government that pays for children, whether they're getting private insurance or it's a public single payer system. And that recognizes children are a social good. We all ought to chip in and pay for their health care, give everyone, whether they're rich or poor, the same health care and the same start in life. I think there's a lot to that. And I think loading all the costs on families is very, very burdensome. I'll tell you another thing that I think I've learned from these countries is to really heavily emphasize primary care. And one of the ideas that I have really liked and this is true in Canada, is no cost at the point of care, especially for primary care. So no deductible, no copay when you go to see your primary care doctor. That would strengthen primary care. And I think it would empower primary care doctors to be the ones who manage patients and coordinate their care and take more responsibility. And I think that is something that would be good for patients and good for the healthcare system in general.
I mean, the thing that really strikes me about kids is we do socialize the cost for the elderly.
Oh, yeah.
Right. And we essentially have created these, for the most part, well-functioning, quite universal programs for the elderly. And it seems like the argument for doing the same thing for kids is actually very similar, which is these are people who are not working, right? And actually from a moral standpoint, it seems like the argument for kids and the elderly are actually kind of equivalent. But from an investment standpoint, actually, the argument to do it for kids is even stronger, and yet we don't do it.
You're speaking to the converted. I 100% agree with you. And I do think it's one of those things that we have, when it was cheap, we put it on families, employers. And now that it's no longer cheap, I think it's one of the major inhibitions to having more children. Is this cost? I mean, it's an enormous amount of cost. Just think, if you're paying $6,000, $7,000 and the median household income in America is $63,000, that's 10% of your pre-tax money just to pay the premium, not the full amount of your health insurance. that's a big disincentive. And then you add on daycare, and I mean, it's a very we've created all the disincentives to having more children in America, and I think it's bad. I think that's one of the most awful things. And when you go to all these other countries, including countries that have, provide their universal coverage through private insurance, the society pays for the kids.
So it seems to me that where we're going in terms of expanding coverage in this country and kind of getting the final way is it's almost certainly going to happen through Medicare. That Obamacare, which you obviously worked on, was this effort to kind of forge a compromise that conservatives and Republicans might support. It included expanding both private insurance and expanding public insurance through both Medicare and Medicaid. But the private markets haven't worked as well as the public expansion for a bunch of reasons. Republican governors haven't really been willing to expand Medicaid, or they all haven't. And people really like Medicare. So it feels like even if it isn't a Bernie Sanders style program, the future of healthcare coverage, expanded healthcare coverage in the United States, is expanding Medicare. Do you agree with that?
Not necessarily, but I would go with it. I don't think it's the only way. But let me highlight a point that you make, David, that I think is really important, which is with the Supreme Court decision that states didn't have to adopt Medicaid expansion and would not lose their old Medicaid money, which basically gave states veto over Medicaid expansion. We have no path to universal coverage because we have 14 what I called them yesterday in your newspaper, implacable states that are not going to expand Medicaid. And therefore, we can't, no matter what we do, get to universal coverage. So the ACA was premised on, here's a path to get there. And yet, we can't. We can get to 95, we could get to 96%, but we can't, like every other developed country, get to 99% coverage or 100% coverage without changing structurally something in the system. Now, yesterday, my brother and I proposed nationalizing Medicaid, which I think is perfectly reasonable thing to do, and you could. It would maintain the complexity of, you got a Medicaid program, you got a Medicare program, you got a employer-sponsored insurance program. You could also think that you might, merge Medicare Advantage, that's the private insurance market, with Medicaid, so people could have a choice of private insurance or sort of traditional government program. There are lots of ways to get to universal coverage, but I agree with you in this regard. All of them go through the federal government. We are not going to get universal coverage by the current structure that keeps Medicaid in the states and allows these 14 states. By the way, they're non-trivial states. They're Texas, Florida, Georgia. They have a third of the American population. So they're holding hostage lots of people. And I think we have to figure out a way to circumvent that situation.
Let's imagine that in 2021, we have a president and a Congress that are interested in legislating on healthcare in a productive way. What would you like to see the next substantial healthcare bill include?
Well, first of all, I think, it seems like a long time ago, December 2019. Top of our list in December 2019 was drug price regulation. And it still seems to me we need to do a lot of stuff on drug price regulation. As I think I say in the book somewhere, we have about 4.5% of the world's population in the United States with 330 million Americans. We have about 40 to 43% of the world's total drug spending in the United States, very disproportionate. Our drug spending is per person is about $1,440, and the next highest country is around about $1,000. That's Switzerland. We really need to bring it down. Every other country, including conservatives' favorite, Switzerland, regulates drug prices. And all of them have some objective measure, and they all link the price you pay to the health benefit from the drug on some objective scale. I think we're going to have to do that, and I think it's really important to do that, not the least of which is you want the incentives for the drug companies to develop drugs that have real health benefits. And not just focus on ones where they can sell it for $120,000 a year. like cancer drugs that give you 4 extra weeks or 6 extra weeks of life. And so I think that would be high on the list. A second very, very important item is we got to solve this universal coverage problem. Absolutely pivotal. And there are lots of mechanisms to do it. We just need to pick one and push it. And as I say, they all drive through the federal government. You got to get Medicaid out of the states, and then we can figure out how we want to structure it. We can think of almost any possible arrangement that would be better than the current one. I would urge a lot of simplification in that process, because the way we have it now, the complexity we have now, adds heavily to the administrative costs, and we could save a lot of money if we just organize it. The third point I would make is we have to do something about affordability of coverage. Get the deductibles down, as I mentioned, get the co-pays, especially for primary care, generic drugs, urgent care, down to zero. We need to restructure how we pay doctors and hospitals. One of the things COVID has done has revealed that all the margin and profit at hospitals is from elective procedures, not the essential stuff, the elective stuff. That seems like a crazy way to go. Pay hospitals and doctors so they can make money on elective, non-essential items, and the essential stuff, we slice it thinly so they're not incentivized to do it. That seems like a crazy arrangement. So we need to fix how we're paying doctors and hospitals. And fortunately, we have a lot of experiments to build on in that regard, and I think we know a lot about how to do that effectively.
Which country in your travels, either actual or intellectual, which country do you think has a drug price system that's particularly laudatory?
Oh, I think there are a lot of them, but if you want the lowest drug prices, you look at Norway or the UK or Australia. I think, in my view, the way Britain actually systematically analyzes the data on benefits and assesses it and does it in a public manner and gets public feedback is very laudatory. Now, we can debate whether their threshold is the right one. Australia, similarly, very rigorous. And I met the person in Australia who actually negotiates with the drug companies. I want to tell you, I wouldn't want to negotiate with her. She is like one tough cookie. And but I think they also have a very rigorous process, very thoughtful process that looks at the benefits, and they buy it as a country. All the drugs are bought as a country in Australia too. So those are two places I would look at, and I think we could learn a lot from.
So just two more things, and then we'll open it up to all of you. This is obviously a moment when large parts of the country are reflecting on the centuries of racial inequities in the United States. Can you talk a little bit about how that intersects with the healthcare system? The health outcomes for African Americans are worse in so many different ways. We're now seeing an extreme version of that with COVID. What does our healthcare system need to do to change so that it is not exacerbating these racial inequities?
So there are multiple things. First of all, there's pre-healthcare. There's the social determinants of health. There's income, nutrition, exercise, housing, transportation, all of those things, employment, all of those things are, stacked against African Americans as a group, not any individual family, as a group, making their health situation worse. Finding a fresh fruits and vegetables in the inner city, getting transportation, all of those things are hard and make it hard for people to actually live healthy lives. Second, we have a problem in the healthcare system. Part of it is suspicion and trust. There's many good reasons that African Americans are suspicious of the healthcare system, and maybe that has fueled some of the not adhering to all of this public health measures for preventing COVID. We need to regain that trust. Facilities in minority communities need to be enhanced. We need to change what is the differential pay. So, employer-sponsored insurance pays the best and Medicaid pays the least. We know that African Americans are disproportionately on Medicaid, and healthcare systems, doctors, they manage patients. They change the access to patients depending upon the pay. It's very hard to make a financial go of it just getting Medicaid reimbursement. And so people manage that. I think one of the things a good reform would do would to be equalize the payment. It doesn't have to be exactly equal, but it has to be within a margin so that you don't have hospitals and doctors making all their money on employer-sponsored private insurance, and you've got a much more equal system. There is a state that has that. It's called Maryland, and it has had it since the late 70s. So I think those are some of the important reforms necessary, and I think it is going to help. It's obviously a slow process to get more minorities in medical school, in nursing school, as respiratory therapists throughout the healthcare system, and that has begun, but it's far from sufficient. And I think that will enhance trust. It will enhance the ability of people to actually feel like the healthcare system is, for minority people to feel like the healthcare system is working for them and that they won't somehow be abused by it.
And I asked you about the medical system, but one of the things we've talked a lot about over the years is the fact that the main determinant of health is not health care, right? And so when you think about some of these other debates we're having, reducing mass incarceration is clearly a way to reduce health gaps between whites and African Americans, right? Because
well, as I began my answer, right? I mean, housing, nutrition, exercise, food, jobs, all of those are critical to actually reducing the socioeconomic disparities and the racial disparities in our work. We know that, I forget the exact number, you'll know it, but for $1 that a white worker makes, African Americans make 70 cents or something like that. That disparity does not enhance healthcare and health outcomes, and we really need to equalize this economic situation, as well as all the other things, improve the housing stock, make fruits and vegetables and other things available in the inner city.
Let's spend one more minute on the virus before we open it up. So we right now seem to be in the situation where a bunch of places that were hit extremely hard early have reacted with policies that appear to be really kind of bringing down virus rates, right? Much of Europe, and actually, in fairness to Europe, parts of Europe that weren't hit that hard have also brought the virus way down. We've seen New York and New Jersey bring the virus way down. In much of the United States, we either are seeing sort of a resurgence in cases, or in many places, they never started falling. They were just low before, and now they're rising. And it just feels like we are not, it feels like we're not, things don't look as positive as they did a few weeks ago. What's your sense of kind of where we are right now and what the next, say, month or 6 weeks is likely to look like?
I think you're right, which is, in late March, late April, late May, we had 20,000 cases a day. Guess what we have in June? 20,000 cases a day. Now they've moved. They're no longer in New York, New Jersey, Connecticut, and they've moved south and west, but it's still the same number of cases. And yes, the mortality rate has gone down, mainly because doctors have figured out how to manage patients better, but it's still way high. We have 115,000 people who are dead, and we'll probably, by the end of the calendar year, have something like 250,000 Americans who die from this virus. But the problem is there are certain things we have to do. There are certain things we have to do them rigorously and stringently, and we just didn't do them. And places that opened up, they opened up more or less all at once. The president's plan, for all its faults, had a few things which were actually quite reasonable. You had to be going down for 14 days, both in total number of cases and hospitalizations, before you began opening up. And then you didn't open up all at once, including nail salons and tattoo parlors and indoor restaurant dining. You opened up in stages, the low-risk places first and higher risk places as we got more used to it and the number of cases kept coming down. Both of those things seem to be violated in states like Florida, Mississippi, Alabama, Texas, Arizona, that have really exploded in the last few days. And contra Pence, who said, well, a lot of this increase is, just testing. You don't get 150% increase over 7 days in total number of cases by more testing. That's real viral community spread. And by the way, it is not, as also he said, just embers. These are real, it's pervasive in the community. Embers are, we're down at 1 or 2 cases a day, and then we see, like in Beijing, 36 cases. That's an ember. But you're not seeing embers when you're having 2,000 cases a day in a state.
Yeah, and I mean, I think another thing that sort of helps point out that this isn't just about our testing. This will be in my email newsletter tomorrow morning. I put together a chart where I looked at these 16 European countries that have essentially an identical population to the US. So you just start in Portugal, move east until you get to 330 million people. And what you see is their death count, not their case count, absolutely plummet. And ours has fallen, and then it sort of levels off.
Yeah.
And so it's just, we're doing something wrong.
Well, I'll tell you, we're spreading the disease, and we're not protecting the most vulnerable in a systematic way. So we've opened up so the disease can spread, and then our most vulnerable, the elderly, institutionalized people, whether it's prisons or other facilities, and people with comorbidities are not systematically being protected. And those are I think, the 2 biggest problems.
Yeah. Okay, we're going to move to your questions. So folks can put questions in the question room and also can vote on them. And I'm going to.
Oh, wow.
I'm going to. Can't promise I'll follow it completely strictly, but in general, I'm just going to pick the questions with the most votes. So please ask questions and please vote. So here's the top one. Actually, it comes right off what we were just talking about. Does the experience of COVID-19, in which some of the more universal systems like the UK and Italy still saw relatively poor outcomes, complicate the overall picture when it comes to isolating the best healthcare system? That's from Daniel.
I don't think so, and I'll tell you why. When I was finishing this book in January, I wrote a coda, and then COVID came on the scene, and my publisher said, rip out that coda and write a coda that's relevant to COVID-19. And one of the things you have to believe is that we're still in the acute phase of COVID, and the acute phase is mainly a public health phase. It's how the public health system responds. Does the public health system test, trace, isolate people? Can you get people to do what we call, non-pharmacological interventions? All those public health interventions, wearing the mask, physical distancing, hand hygiene, staying out of crowds. Those are public health interventions. Those are not about the healthcare system. If you ask about the healthcare system in our country, and I'll leave the supply chains aside because I don't know that that's part of the healthcare system as most of us think about it. I think that we've done a pretty good job, and we have excelled exactly where I thought we would excel, which is we've excelled at innovation. We've excelled at learning about this. We do more research than most other countries. We're systematically gaining information. We adapted and managed well. So I am not convinced that you learn much about the healthcare system. You learn much about the public healthcare system, and our public healthcare system has been starved for funds and denigrated by this administration. And that's why part of the reason I think it responded so poorly. Let me remind the listeners, lest you need reminding, you probably all know this better than I do, which is in the budget that the president submitted just before COVID hit, he had a 19% cut in the CDC. All right, that tells you everything about how he valued it. And, you want to know why it didn't respond so well. There are many reasons. The leadership hasn't been great. A lot of researchers and scientists have left because their work was not considered valuable and denigrated. It wasn't working well with local and state public health agencies. So COVID in this acute phase reveals more about public health response, not about health systems, which are about hospitals and doctors, et cetera. So is my take on whether my conclusions are disproven by the COVID epidemic. I will say that a number of countries that I did look at, like Norway, like Germany, have done remarkably well, and for reasons that are related to, partially related to their healthcare system.
Okay, from William, how do countries with better systems deal with medical malpractice?
Good question. And I'll tell you honestly, we didn't look at that. It wasn't a big issue, in part because it's mostly not an issue in all these countries. I can't remember a single interview we did where someone said, well, you didn't ask about medical malpractice, big problem here. It is a slightly growing problem in many countries, but it's hardly the problem it is here. And by the way, it's well blown up here as to be a bigger problem than it really is in terms of the healthcare system. You know, when doctors tell you why they do unnecessary tests or do unnecessary treatments, they always blame the malpractice system. Well, if I didn't do it, I could be sued. But the fact is that is actually probably totally untrue. We've got a lot of data that if you change the malpractice system to protect doctors, you don't get a decrease in unnecessary care. You actually do, some evidence, a decrease in the quality of care. But you don't actually get a decrease in a lot of unnecessary care because there's many motivations for getting that beyond malpractice. You get paid to do it. That's how you were trained, and it's a part of your habit. So I think that I'm not one of these people who believes that malpractice is the source of all evil. It's a fairly small part of our system, and I think a fairly small part of the motivation of our system. Nonetheless, I was one of the people trying to convince President Obama to put into the ACA malpractice relief for doctors, because I wanted to get it off the table. I wanted to change the doctor's psychology, not because I thought it was actually an important driver. It's an important excuse, not an important reason for behavior.
Actually, and to me, that's a fairly good example of Republicans made a strategic decision basically just to block this bill. That is something that I assume they could have had easily if as a condition of their support for the bill.
Absolutely, totally.
Okay, I'm going to hoist a question that doesn't have as many votes as the one at the top. I'll come back to the one at the top because I wanted to ask this as well, and I just forgot to. From Tina, how do you account for R&D costs for drug companies that they say are what's driving up costs? How would that be accounted for in a more functional system?
That's not in this book, but it's an extensive argument. So, you know, they claim it's $2.4 billion per drug. Almost everyone agrees that number, which comes from Tufts Center, is probably wrong. I'm an oncologist, I think, as Brad mentioned at the start. If you look at cancer drugs, and there's a very good study in the JAMA Internal Medicine IM that looked at cancer drugs, all the cancer drugs that had been tested in between a few years, and you get about $600 or $700 million per drug developed. All of the drugs but one, all of the 10 drugs but one, actually made back their entire investment and plenty more in just a couple of years. You didn't need 10 years to run things out. And because cancer drugs are so highly paid, you've got over 600 drugs in development. And so you've got these very, very perverse incentives. The drug companies are heavily focused on cancer. On the other hand, you know, antibiotics you can't charge a lot for. You develop a new antibiotic, it's not going to be used a lot because it's going to be the last stitch antibiotic for a antibiotic-resistant bacteria. There are less than 40 in human trials. And so we have a lot of perverse incentives as a result of trying to pay for the R&D costs. It's a long analysis. I've written a lot about it in Health Affairs about why that assessment of the drug R&D driving drug costs is just false and inaccurate.
And so you think it's basically market power. They have the ability to charge high prices, so they do.
Here it is. We give them a patent. Usually it lasts around 10 to 12 years. We then approve it and prevent other people from infringing on that patent and give them marketing exclusivity. And then we let them set the price. Every economic theory and economic practice tells you that is a recipe for prices going to the point at which they will, as high as they will go before they decrease profits because people stop using them. And that's what we've got. It's just that simple. And by the way, in healthcare, it's even easier because you and I aren't paying. The insurance company, a third party, is paying. So if I need something, I'm not going to worry about it because someone else is going to pay the bill. So I don't care what that price really is, realistically.
Okay, from Elizabeth. Do you think that universal coverage would actually increase the overall cost? Wouldn't total cost go down?
So as I think I mentioned and maybe didn't emphasize enough, if we do universal coverage in the right way, we can certainly bring down administrative costs. Bringing down costs is something I have really worked hard on for the last 10 years. I think the fundamental procedure there is to bring down costs is going to require some price regulation of hospitals and other parts of the system like drugs. But it's also going to require paying doctors differently. A large part of the costs in our system are unnecessary care, inefficiently delivered care, giving care in high cost places when there are low cost places that get the same outcomes. So I think there are ways of driving costs down without compromising quality. And, as we learned in the Affordable Care Act, you can add a lot of people to the system and you don't have to drive the price of the system up. We added 22 million people, and actually the estimated costs were lower than we had predicted before.
Okay, Lynn asks, I agree that Germany and Holland have a private sector that handles healthcare. However, I understand they are nonprofit. Is that correct? And what impact does it have on the cost?
Their insurance companies are not for profit, as are the ones in Switzerland too, at least on the healthcare side. A lot of these insurance companies, they do make some profit when they sell supplemental insurance in some of these countries. I'm not sure it drives a lot of that it's the big driver here of costs. We had 25 years ago, a big debate about for-profit hospitals versus not-for-profit hospitals. And there was all this attention, the for-profit hospitals, they're driving up prices. In the end of the day, the analysis showed the for-profit hospitals were not driving up prices. To some degree, they were community hospitals and more efficiently run when they were for-profit. And by the way, the quality outcomes were, as far as we could tell, not much different between the for-profit hospitals and the not-for-profit hospitals. So I am skeptical that that's the main thing. And by the way, in America, we have a lot of not-for-profit insurers. You should not think that all insurance companies are for-profit. A lot of them are not-for-profit insurers. A lot of the Blues are. We're familiar with the big for-profits, United, Cigna, Anthem, Aetna, Humana, but there are plenty of state Blue Cross and Blue Shield plans which remain not-for-profit, and they still have costs that are pretty much just as high.
Okay, Tina, was France a country you looked at? I know the answer to that question. If so, can you give a comparison of France to the U.S.?
France was a country we looked at, and it's hard to do it justice in a minute or two. But let's say France is an interesting case, and actually the interesting contrast is with Canada. So France covers a lot of healthcare services, but pays a very small amount. And so 95% of people in France have to buy supplemental insurance to cover the copays and other elements supplement to the statutory health system. So they actually have comprehensive services, but the payment by the government is low and people need supplemental services. I'd say people have a very good choice or free choice of doctors, and they like having the choice of doctors, both primary care doctors and specialists. If there's a real problem in France, it's the lack of coordination for chronic care and really lack of focus on chronic care. There are many other problems. That's not the only one, but that is I would heavily emphasize that. We saw it repeatedly. They were very interested in how we were paying to get better coordination of care. Canada, interestingly, is a country that has a smaller benefit package than France, but it zero copay at the point of care. So you go to see the doctor, you go to the hospital, you're not really paying. And I think it's an interesting, and as I mentioned, Canada doesn't cover drugs. So it's an interesting contrast between the two countries.
Before I'm going to try to sneak in one or two more here before we're cut off. But before I do that, I just want to remind everyone, and no one asked me to do this, what an important local institution Politics and Prose is. And they've been shut down now for weeks and weeks and weeks physically. We can hope they will have a chance to open soon. But in the meantime, I just wanted to encourage all of you to buy a book or more than one book. Buy Zeke's book and a second book through their website. You can do curbside pickup. You can get it shipped to you. I think we all would be very sad not to have Politics and Prose as part of our city. So I just want to add. We talked about Mike Pence a little bit. There's a question here asking you to address his Wall Street Journal op-ed saying that COVID will not have a second wave and that the media is blowing it out of proportion. That's from Zaina.
Well, I wish our people would stick to what they do best, politics and not medicine or epidemiology. First of all, as you and I mentioned, David, the cases have been relatively flat, 20,000 per day going up, and we haven't really seen a big change. That's community spread. It is true we haven't seen going up to 40,000 cases per day, but nor have we seen it drop as it has in most other countries that have responded. It has moved around, and so you are seeing exponential growth in a lot of places that didn't have it before, while you're seeing exponential declines in places like New York. And for those of you who want to see this, just go to the New York Times where they have each state, and you can see the nice drops in cases and deaths in New York and rise in places like Florida and Texas. I think in the summer we have this huge advantage called the outdoors. We live outdoors. It's harder to transmit the virus outdoors. And I think that's going to give us a big reprieve this summer. It's one of the reasons I advocated opening up summer camps for children that could be outdoors and get kids to have a more normal life. What I'm fearful of is October, November, December, when we move indoors because of the weather. And that's, what are the 4 ways that the virus really spreads? In closed spaces, with crowds, for prolonged periods of time, and forceful exhalations, yelling, screaming, coughing, sneezing, singing. And then, you move indoors and do have that combination of things, and that's when it's going to spread. And I'm sure that's when we're going to have a second peak. I think it's almost inevitable. And by the way, I think Vice President Pence is hoping we don't, because if you go back and read about the 1918 flu pandemic, the second wave, the wave in 18 and 19, was much worse in terms of mortality than the first wave.
When did it begin? Do you remember?
Well, we had, in the spring of 18, and then you had in the fall, late fall, I think it was November, it began to go up. And you have a very, very high peak in terms of mortality. It's the highest of all. That there are 4 main peaks of mortality, and it's the highest is the second wave, that second winter, that first winter. So I'm very fearful. That's what keeps me up at night. And by that time, people are going to be, I'm fed up with the physical distancing. I'm fed up with the masks, blah, blah, blah. And that's what worries me, unless we have a very good leadership on this.
Yeah. Okay. I think this is probably our last question from Natalie. What was your selection process for the 11 countries in your book?
Well, we talk a little bit about it in the introduction. So we wanted to get countries with a diversity of financing, a diversity of histories, and represent, you might say, different political views. So I wanted a Scandinavian for all those liberals and progressives who like all things Scandinavian, including the furniture and the architecture. I wanted Switzerland because it's often a darling of conservatives. I wanted to look at the Netherlands because it is a model of managed competition, which has been one of those approaches advocated in the late 80s and 90s and inspired the Clinton reform. France had been rated #1 by the WHO in 2000, so we thought we should include that. Of course, Britain and Canada are always, whipping boys for American conservatives. We had to include those. Taiwan, I'd been told by many people, had a system with high satisfaction. Wanted to look at that. Australia, I had been to and met the people who regulated drugs, was very impressed by certain parts of it and unimpressed by other parts. So we tried to get different geographies, different ways that they funded it, different histories, different political systems, and also making sure that we answered questions from all different partisan or political viewpoints in the United States. So while I didn't do Sweden and Denmark and Finland, I got Norway, and it's not exactly the same everywhere, but pretty representative.
And finally, what are you going to say when people now ask you the question in your book, which country has the world's best healthcare?
I do my best to evade the question. and one of the things I will emphasize is it really depends on what you're concerned about. You know, some people are really obsessed by waiting times. Okay, Canada, UK, Australia, no-goes. You know, Germany, Switzerland, those are places that have short waiting. If you want no copays at the point of service, you know, the UK, Canada is good. Australia, and hospitals, there's no copays if you go to a public hospital. If what you're really interested in is free choice of all your doctors, primary care as well as specialists, you know, then Germany, Switzerland, France are really high up on your list. If all you want is really good choice of primary care doctors and you're not so particular about specialists, then, you know, Netherlands, Norway, are good choices. So I think it really depends on what you're focused on. If you're really focused on, I want a stable, you know, I'm an elderly person, I want a stable system for financing long-term care. There are only 2 countries that do that, make it part of the healthcare system, and that's the Netherlands and Germany. All the rest of us are like kind of chaos. We don't have good financing, and we're trying to piece it together as the population ages. So I think a lot of it depends upon what are you particularly focused on.
David, I thought you were never going to ask, and Zeke, I knew there was not a simple answer. But thank you both for both.
I'm an academic. We try to make everything complicated.
Everything complicated. But thank you both for a great, very illuminating discussion. You know, if we can't travel freely abroad for the time being because of the pandemic, we can at least all live vicariously through your book, Zeke. And David has expertly plugged the book already. And plug P&P as well, for which I'm grateful. But I'll say again, you can order copies of Which Country Has the World's Best Healthcare by clicking on the green bar below. Thanks again to everyone for tuning in. From all of us here at Politics and Prose, stay well and well read.
Thank you, Brad. Thank you, David.